All right, thanks everyone for bearing with us here. Today it's my pleasure to introduce Professor Colleen Reid from the University of Colorado Boulder. Professor Reid received her bachelor's in environmental science from Brown University, followed by a Master of Public Health and PhD, both in environmental health sciences at the University of California, Berkeley. She was then a Robert Wood Johnson Health and Society Scholar at the Harvard T.H. Chan School of Public Health. Since 2016, she has been a professor of geography at CU, where she is also a faculty fellow of the Institute of Behavioral Health and Science and Earth Lab, and she is currently the interim director of CU's new bachelor's degree in public health. Her research is focused on the role of green space in public health and the health impacts of extreme heat events and exposure to air pollution from wildfires. Before starting, I'd like to remind the folks following online, you can enter your questions in the space below the video at any time during the talk, and then at the end of the presentation, I'll read those questions. So, Colleen?
All right, thank you. So today I'm going to be talking about work that I've done on the Marshall Fire, and I will start by talking about the fact that I've been doing a lot of work over the years on wildfire smoke and how it affects health, and I'm predominantly trained in environmental epidemiology and exposure science. So my work on air pollution is more to quantify exposures and then link them to health outcomes. So I did say to the folks that invited me, you know, this talk might be a bit more on the health side than on the air quality side, but we'll get into that. So a lot of my work before this project on the Marshall Fire in particular was focused on trying to assess exposure to wildfire smoke, and this was mostly focused on PM 2.5, but a little bit on ozone, and all in outdoor environments. So we were trying to use a combination of monitoring data, satellite data, and chemical transport models, meteorological data, and machine learning to do spatiotemporal models of exposure, but then more recently, getting into the use of low-cost sensors to assess exposure to wildfire smoke, and then linking that to health outcomes. So I have work starting with the 2008 fires in California, linking to hospitalization data or emergency department data to try and assess the relationship between wildfire smoke exposure and respiratory and cardiovascular health outcomes. But I've also been involved with sort of lots of papers talking about what everyone else has done on this topic. So I have a good sense of what we do and don't know at this point about the health impacts of wildfires. And so when the Marshall Fire happened just in our backyard here in Colorado, I was contacted by lots of people. I think they were looking for people in the area who knew things about health effects of wildfires. And what I came to realize pretty quickly that this was really different in a lot of ways to think about health compared to what I had done in the past. So as much as, and I know all you know this, but the Marshall Fire started in grassland, most of what burned was human-made material rather than vegetation. And so this image on the right, I think is really interesting in showing, you know, just the sheer number of structures that burned, but then additionally that some of the trees in people's yards got singed, but not completely burned. And so most of what was burning was not just structures, but also vehicles too. And then there were also these homes within the burn area that did not get destroyed. So you can see one house in a community in Superior that somehow managed to stay standing. And then this is to the right, another one where basically like one block is burnt down and another block was saved. And the interesting thing about that was the winds were so high that day, even though it was a relatively short-lived, in terms of time, fire, so many structures were burned and the wind was so high that the people who came back to these homes found ash everywhere. So these are some pictures we took. Basically because researchers' homes were affected and other people we knew were affected, they were allowing us into their homes, and we saw ash in not just inside doorways and windowsills where you'd probably expect it, but everywhere. And so a group of colleagues of mine who are much more on the chemistry or the air pollution side of things, we're able to go in and assess, take samples of the ash. And we noticed right away what people were telling us is that those homes smelled really bad. It was actually really interesting. It was 2021, so we got in there at the first week of January in 2022, and it smelled really bad if we pulled down the masks we were wearing because of COVID. And so we were, so everyone was concerned about this. Additionally, what makes it unique is that the next day we got snow, and the snow cleaned the outdoor air. And so I was first tasked with just getting the purple air data that was available in the community, because there's not a regulatory monitor in Louisville or Superior. And the plume was really, I know that NCAR researchers modeled it, and I've seen that model. So it was kind of narrow spatially. And so it wasn't affecting some of the regulatory monitors north or south of there. And so we tried to look at the purple air data, but because one thing that was done to fight the fire was to cut the power to the area. And so the monitors that people had owned prior to the fire were pretty much cut off at the peak of the smoke plume. And so we couldn't say anything about the outdoor air. But additionally, outdoor air wasn't the problem long-term. The long-term problem was the indoor air. And so and around that time, there were some publications that came out from the national academies, as well as groups headed by researchers at the US EPA, that compiled data from experimental studies that show that emissions from burning biomass are different than emissions from burning human-made materials. So we expected to see quite different chemistry or quite different air pollutants from the burning of houses and vehicles and electronics. And I use that as just background for the interest and my interest in these WUI fires, where what's predominantly burning, as in LA recently and in Lahaina and many other places, human-made materials. And then the researchers that I was collaborating with were able to, as I said before, take some ash samples. So we have we have one publication that's from my research group and another one. So the one on the left is, I was affiliated with Mike Hannigan's group, was leading that part of the project, where they put some pods with a bunch of low-cost sensors in 8 homes and also collected ash samples to look at the chemistry of the ash, and found that the dust in the smoke-damaged homes had elevated levels of polycyclic aromatic hydrocarbons and some metals. And then another group at CU did some soil sampling, and could have included some of you here. I know some of the folks at CU who were part of this, that also found some elevated levels of metals in the soil near damaged homes. And so that's all as preface of, there were these chemicals in the ash inside the home or outside the home that could have been affecting people who had these smoke-damaged homes. But then additionally, Joost de Gouw's group, they put their large GCMS in one home and found very high levels of some VOCs, and that did decline over time. And then additionally, within this study that was recently published by Joost's group, they found that there were increases in, it was in the first paper by Silverstein. We found that in the homes where we were sensing indoor levels of PM, we found that the PM levels were low, except when people were cleaning. People told us when they were cleaning. And so my theory that sort of led behind this was that people were concerned about the smells. The smells could be due to these VOCs that we were finding in the few homes we could sample. It could be, and then they were also concerned about this dust. And the dust was particularly a concern if it could be resuspended and inhaled, or ingested if children were to touch it and we know children are just so commonly going to touch everything and put their hands in their mouths. And hopefully adults don't do that, but they might as well. And so I was concerned about this, but we would not be able to, we couldn't, the GCMS, you all know, is very expensive and very large. We can't put it in all the homes we would need. And for a health study, you need just large numbers of people to get statistical power. And so I was brought in for the health side of things. And I also realized we couldn't sense in all these homes to get exposure measures. We also couldn't wait to get health records from, say, hospitals. That was going to take many years before we'd be able to get that data, and people wanted answers now. Additionally, people were complaining of symptoms, and many of those symptoms so in the US, we only have regular collection of death data, hospitalizations, and emergency department visits for the most part. You can get electronic medical records. There's challenges with that too. Which I'd be happy to talk about another time. But people don't normally go to their general, even a physician visit with complaining about, oh, I have a cough, unless it's really serious, right? So these symptoms people were experiencing are important, but they probably weren't going to show up in these medical records. So we decided to do a survey where we could survey on people's perceptions of their air quality, even if we couldn't sense everywhere, and we could also survey on their symptoms. And so the goals of our study were to understand the physical health symptoms of people living in smoke-affected homes after the Marshall Fire, and if those symptoms persisted or improved over time. If there was spatial clustering of perceptions of air quality or physical health symptoms, and I'll get into why we thought that was important, and then to assess any proxies of physical exposures if they were associated with the self-reported symptoms. And this took a while because so many researchers were interested in studying this because we have so many researchers in the Boulder area, and they all wanted to study their area of impact. And I think it's also really important as we have more in these WUI fires that we have all that research going on. But we didn't want to overburden the population with survey after survey after survey. You'd get really low response rates if you do that. And so a colleague of mine at the Colorado School of Public Health coordinated people to make one unified survey, which took a lot of time to get everyone together on. So the first wave of the survey, which is included in what I'm going to talk about today, didn't get to the population affected until about 6 months after the fire. So it was in May and June and July of 2022. And then I'm also including wave 2 of the survey, which went out about a year after the fire. And so this is a long lag time, and I was really concerned that we wouldn't actually see much, that all the symptoms that people told us right afterwards would have improved by that point. But we still thought we'd go ahead and look at it. And everyone who lived within the fire perimeter was invited to participate in the survey, and then a random sample of people up to 2 miles outside of the survey area, because those areas were also evacuated and had other impacts as well. So within the survey, it included people whose homes were completely destroyed, smoke damaged, or not damaged at all. But for this, what I'm going to present on here, we only wanted to include people who had a home to return to, because the people who lost their homes completely, most of them were living outside of the area affected. So we can compare the people with smoke-damaged homes to not smoke-damaged homes who were affected by this fire in the area. So I'm going to start with what were the physical health symptoms of people and if they persisted over time. So actually, this table here, column 1, is all the people who had a home to return to in wave 1, and then of those who responded to wave 1, who responded to wave 2, and everyone who responded to wave 1 was invited for wave 2, but we had some attrition. So it includes people who had smoke-damaged homes or not. We'll get to the difference between the two in a little bit. But what we saw in this was that there were still quite a bit of symptoms being reported at 6 months and a year after the fire. The way the question was worded, it asked them to only check any symptoms that they attributed to the fire. However, we recognize that there can be people could respond to symptoms that may not be due to the fire. So what we can see here is, and we don't have sort of a representative data set of like, what % of people on any given day say they have a headache, or things like that to compare to. So at first we didn't know if this was higher or lower. So we'll get to that later, but we do see that, and people could report multiple symptoms. So this is just the % of the population saying, so 55% reported at least one symptom, but the most common at 6 months after the fire that people thought were due to the fire were itchy or watery eyes, headaches, dry cough, sneezing, and sore throat. that all of those symptoms did statistically significantly decline by the 1 year mark. However, we still have about a third of people reporting at least one symptom that they believe is attributable to the fire. And then we also asked questions about perceptions of air quality. So we had a bunch of those questions. I'm only going to focus on a few of them here. We had people state at 6 months post-fire, remembering back to 1 week after the fire when they were first allowed to go back to their property, did their home smell differently? And I mapped this one, and you can see that the people who said their home smelled differently are the blue dots, the red are that said that it didn't smell any different, and then those gray dots are destroyed structures. And so we felt like there was we felt like the people who lived closer to the destroyed structures were much more likely to say that their home smelled differently. And then the home smell type, we gave them a few options. This one's a little tough to use in our analysis because of the people who picked other, most of them picked, and this is a survey design problem, both. And we should have had an option for both. So like a campfire, like a chemical fire, or other. And most of them who said other said it was both campfire with chemical smell. And so it's a little bit harder to see. And then we do point out here that more people who said that their home smelled differently when they returned home after the fire, most of the people who had a damaged home, either they were living there or not living there at the time of the survey, the majority of those said that it smelled differently after the fire, whereas less than half of those who had no damage said that there was a change in smell. So at that point, we thought there's probably some spatial clustering, and the spatial clustering could be due to being close to these burnt structures. So we used Moran's I, which is a spatial statistic that is basically a correlation where you weight by neighbors. And so it's only correlated when comparing yourself to what's defined as your neighbors. And so it depends how you define neighbors. So we did 4 different measures to define neighbors. It was and this is just of people responding to the survey. So we did ones where everybody gets neighbors. So every person is given the 5 nearest survey respondents to them as their neighbors, one where it's the 10 nearest. But then we also did by distance. And the first one, we did a threshold that's just under 2 kilometers. But that was the distance where every survey respondent had at least one neighbor. But some people had a lot of neighbors. And then we also did a threshold of 500 meters, so half a kilometer, and that dropped 6 people from our analysis. And so with that, we want to see consistency because we don't know what the correct neighbors is in terms of is there clustering of these symptoms. So if we found consistency with across types of neighbors, we felt pretty confident that there was spatial clustering. And so this map shows where we see those spatial clusters. So the way to see these maps are each point, and they're all the maps, all the points are slightly jittered, so you can't figure out who anyone is. But the red dot is someone reporting the symptom, and they live near others who have that symptom. And a dark blue is they're reporting they don't have the symptom, and they live near others who did not report the symptom. And then the pink is you have the symptom, but you live near people who don't. And the light blue is you don't have the symptom, but you live near people who do. So kind of the light blue and the red are clusters where you have a good number of people reporting the symptom. And then the gray dots are, again, these respondents who did not, and I think some of the gray dots fell out because there's white on top, which are people who don't fall into any of these categories. So I'm sorry about that. I should fix that. But you can basically see that there's clustering of headaches just east of a lot of burnt structures. The sneezing cluster is somewhere else. So, but there were some burned structures in that neighborhood, but it's a different cluster than we have for sore throat, headache, itchy or watery eyes, and strange taste in mouth. We think possibly the sneezing could be due to just that neighborhood is passing a cold around, and that's the clustering that's going on. But it's hard to say. This time point is for the 6 months after the fire, which is in the May-June period where we be less likely to have influenza, but it was during COVID, and so there were definitely infectious agents going around. This one is spatial clustering, the same types of map, but for different perceptions of air quality. And so you can see here that red cluster showing home smell change cluster and finding ash in the home, which is another exposure metric that we used. And then we also had just neighborhood air quality perception and home air quality perception, which had, so I should go back for a second. So all of these symptoms are just the symptoms where 3 or 4 of the neighbors were consistent. So we felt that we could say pretty confidently that there was spatial clustering. And then for these 4 exposure measures, all of the neighborhood methods were statistically significant. So we felt pretty confident that there was some spatial clustering. So based on that, we wanted to assess proxies of physical exposures. We couldn't measure them. We can't get the actual levels of, say, VOCs in the homes or metals in the ash in the homes, but we wanted to give some measures of physical proxies and if they were associated with symptoms. So we were mapping the locations. The purple here are the burnt structures. Those are the completely destroyed ones. The red, green, blue, and purple. At first we thought we'd designate between damaged and destroyed, but we had looked at them all together and we did measures, and the black dots are survey respondents. And so we then assigned for every survey respondent a measure of the number of destroyed buildings within 250 meters of the home, the distance to the nearest destroyed building, the count of the destroyed buildings within a larger distance, so 1,000 meters, but only in the westerly direction because the winds were predominantly coming that direction, and then distance to the nearest building in that sort of direction of where we thought the winds would be coming from. And we then assessed all of those GIS-based exposures as well as responses on a variety of measures from the survey of exposure. I have a full table on this that I could show later, but I'm simplifying it to just a few. But because I think they're the ones that are most closely related to what we would think of as exposures. So what you can see here is these are, we used logistic regression to see how well each of these proxies of exposure was related to each of our symptoms. It was lots of testing, so we did the most conservative adjustment, which is the Bonferroni adjustment, to not have to be less likely to have spurious statistical significance for the associations. So the ones in bold are statistically significant even with that Bonferroni adjustment, showing that, so for example, home smelled differently 1 week post-fire was statistically significantly associated with dry cough, headache, itchy or watery eyes, sneezing, sore throat, and strange taste in one's mouth. And then interestingly, headache, with all the ones here and the other ones I'm not showing you, was statistically significant for every single exposure metric we had. I think what's also important is to point out that some of these, so for example, like just to interpret an odds ratio here, finding ash in one's home was associated with a 3.3 times the odds of reporting headache compared to people who did not find ash in their home. And we found that, and then the GIS measures, so for example, having more destroyed buildings within a 250-meter radius of your home was associated with higher reporting of headaches and strange taste in one's mouth. The underlined ones are if we used a slightly less stringent multiple testing. It's still adjusting for multiple testing. It's the FDR method. And so we think that those are possibly related, but sort of not wanting to overstate findings until we were to do this with larger sample or in other places. So from this study, we found that reporting that one's home smelled differently after the fire was statistically significantly associated with 6 of the symptoms that we thought we might see, but not all of them. The change in smell that people reported could be due to off-gassing of VOCs, and our previous work had found that VOC levels in the smoke-affected homes were elevated in the few that we could sample in post-fire. And we know VOCs are smelly, and previous work on VOCs and health have shown that some of these VOCs that Yost's group had found elevated are associated with eye, nose, and throat irritation, headaches, allergic skin reactions, nausea, and more. With the ash, it was only statistically significantly associated with headaches, but there was a problem with the survey where this was only sent to a subset of the people who responded and not all of them. There was a glitch in the programming. So it could be that we didn't have statistical power with the ash question to see as many relationships as we saw with change in smell. There was some evidence that it might be associated with sore throat or cough. So our study had found high levels of PAHs and many metals in the ash, and we found that the ash could get resuspended upon cleaning such that it could be inhaled. And when studies have shown that, say, for example, copper inhalation has been associated with irritation to the nose and throat. And additionally, the ash samples we had found had some high levels of some PAHs, and that's been associated with sick building syndrome, which can cause headache and throat irritation. And then the proximity to burnt structures, we found living closer to burnt structures was significantly associated with reporting headaches and a strange taste in one's mouth. And there was some evidence for a sore throat. Prior work has shown that when structures are burned, the emissions are different. And some of the things that have been found to be emitted from burning structures could be associated with some of the symptoms that we found. But there's a lot of limitations of this work. It's in such small font because I wanted to make sure I had it all there. We couldn't sample, right, in all these homes. So we don't know the actual levels. We also don't have information on how much time any of these individuals spent in their homes such that they would have been exposed. We've also done interviews, which we're sort of combing through to get at different things, but that's, again, a different group of individuals. So we can't assume any associations that hold at the group level, hold for individuals. I've been asked by lots of individuals affected by the fire if I can prove that what they're going through is due to that exposure, and I can't do that. And we may have missed some physical health impacts. So for example, and we've asked questions about mental health, and we're looking through that, and there is a mental physical health connection in the body that could be playing a role. There could be self-report bias and reverse causality, right? So people who experience symptoms might be more likely to report exposures than people who didn't experience symptoms. But we think that the GIS-based measures, which is not self-report, and the findings there bolsters our argument that at least some of the findings are probable. And then, yes, and I said here before, some of the symptoms could be due to psychosomatic pathways. However, we contend that whether the physical health symptoms are due to chemical exposures or psychosomatic processes doesn't make them any less real to the people experiencing them. And then there was the potential confounding of seasonality. So there could have been, the sneezing could have been due to seasonal allergies. The winter time could have been more due to illness. But I do think that as far as I know, this is the first study to look at physical symptoms of people returning to smoke-damaged homes. And this is continuing to occur with the LA fires, the Maui fires. We were surprised there was nothing from fires in 2017 in Northern California about this impact, and we think it needs to be further studied in these other WUI fires. There's evidence that WUI fires are increasing. It's not just our perception. So people want to know what they can do. So we've been trying to get a lot of information out about that. We found that people in our study on surveys said that the list of things there helped improve the smells in their home over time. Again, that is about perception and not necessarily about the chemical concentration in the air. But we've also found work, and then in our work, so Joost de Gouw's group, they found that using carbon-activated filters could reduce the indoor VOCs. And then Delphine Farmer's group at Colorado State University, they did an experimental study of creating a smoke-damaged home and found that in addition to using air cleaners, cleaning all the surfaces really helped sort of decrease what they believe is the sink that leads to those high VOCs in the homes. And we've been trying to get this information out. So Yost and I have been doing a lot of fielding of media requests related to the LA fires, and Christine Wiedenmeyer and others at Ceres put together this How to Mitigate Your Home. After the fire, I did a paper in the piece in The Conversation about this work from the Marshall Fire, but then we redid it to talk about other wildland urban interface fires, because we really don't know. I mean, even I can't say, like, if you do all these things, are you less likely to have those symptoms? We actually don't know that at this point in time. But I'm hoping that this will garner, get more people to do research on this topic as more people have these homes and they're not sure what to do after the fire. And with that, I'll stop for questions with my acknowledgments of all the funding sources and collaborators. And yeah, I'd be happy to take questions.
Yeah, go ahead.
No
We've got
mic?
ceiling
Okay,
lights.
you have to speak up. So what was not clear to me, so you excluded people whose houses are completely burned, could not go back. So you have the people who have a house in the neighborhood can go back, but did they really live there?
So what's interesting, we don't know how much time they spent. We do know whether they were living there at 6 months post-fire. And when we look at that, there's actually more symptoms among the people who were not living there. And we believe that's because of their symptoms, they don't feel they can go back. And so it's kind of a challenging thing to navigate in that regard, because there's a lot of things that can affect the symptoms. It could be the duration or the actual chemicals that were in the home, but it can also be the sensitivity of the individual. And we know a lot less about that. So that's hard. And I think that another study going forward would want to really get a sense of the amount of time in the home, but it may or may, I think it could may or may not correlate, because I think people who, so for example, in our interviews, which we'll get into this more, there's individuals who talk about going back once a week to clean on their own. And each time they go back, the symptoms come back. So then they leave, and then it gets better when they're not there. There's a lot of different things going on. And then you'll talk to people who are like, yeah, we cleaned it and then it was fine. Right? So there's a lot of variation in terms of people's, possibly people's sensitivity, but also people's concern about what's going on. There's a lot of,
And maybe also perception, what is clean, when
right.
you have people who only think their home is clean when you use chlorine, and chlorine is toxic. So
Right.
that type of perception is also.
I mean, there's a lot of anecdotes I can give on that, but there's definitely people who said that, they completely removed all the furniture, everything, got totally new stuff, and then it smelled worse, and it was really, well, new furniture gives off VOCs. It might, and so there's just there's a lot of variables to deal with in terms of the way that people, and, some people hired companies to clean, some people clean themselves, some people, despite the cleaning, would, never feel safe again, right?
Yeah.
And so there's a lot of challenges there.
Go ahead.
So, and the spatial distribution of the effects, with, I guess let's take the smell, you had the northern part had less than the sort of central part. And I was wondering if that was because of just the time that the wind was blowing, like basically the smoke exposure because of the wind patterns.
So, yeah, so when I looked at the modeled plume, but I believe it was someone here who modeled, and I sort of saw it, I think, on social media or something, but I didn't have that data. It looked predominantly sort of from west to east, the wind was blowing. And so we tried to capture that in terms of those measures sorry, I didn't put the findings in here, but I can tell you what they were. So we also included just the count of destroyed buildings within that sort of where we thought the smoke would be coming from. But it's a crude measure of that for sure. those findings, again, it was for both of those measures, it was just headaches that was associated with that. And so maybe that's all that's there. It could be that that's not exactly the right way the wind was blowing, or it was sort of our crude measure trying to attempt to get
Yeah, I had, oh, sorry.
There's two of you over here. So.
Sorry.
No, I was just wondering, or I don't know if I missed it, but in the survey, did you include all ages, or did you split in children and adults, or do you expect some differences?
We did not, for IRB reasons, ask children, because that requires additional consent processes. So this is adults, and so it was about the person responding to the survey. So we don't have information on symptoms among children.
This is only adults.
It's only adults. And it's also, I mean, it's a pretty good response rate for a survey because people really wanted to share their experiences on this, but it still was the people who chose to respond to the survey. And so they're, as much as based on some of the demographic factors that we looked at, it seemed to be representative of the population. It could be that the people who responded outside of those demographic characteristics that we can look at were different than the people who didn't respond in some way that's important for
Do you expect a difference in symptoms?
for children compared to adults. I don't know. I actually don't know. I think that from my perspective, there's a lot of heterogeneity within the population that might not, for this, that might not be due to age, but due to other things. I don't know, I'm just trying to think of it could be about pre-existing symptoms or like there's, just in terms of these chemicals, like there's the whole chemical sensitivity. Yeah, I'm not an expert on chemical sensitivity either, but I feel like I need to dive into that a little bit. But I don't know about children. I think that everyone's much more, so in my other work of wildfire smoke, we've actually found, and it's quite heterogeneous in the literature, looking at if there's more effects among children of wildfire smoke exposure on health than adults, it's mixed. And I think the mixed thing there is, at least in my work, we found that adults were more effective than children or the elderly, and we think that's because of adults making sure their children are following the public health guidelines and not following it themselves, which is really, that's pretty well documented. Like parents will be concerned about their children breathing these things in, and then lots of the questions that I get from people about the Marshall Fire, like, so this happened while my child's lungs were in a particularly sensitive phase of development. What will be the long-term impacts? And we don't have any information on long-term impacts here at all, and I think you need to study that. But additionally, if there are sensitive time periods in children's development that might affect their longer-term respiratory health, that's a very open question that we don't know, even for, I'd say, air pollution in general. Right. Yeah.
One data kind of health data source that you may have access to or you definitely could look at would be prescription fill data, especially in that 1 year period post-fire. It would be really interesting to see how that tracks for your individual census blocks or whatever, because I think it is available at the census block level.
Who would you get that from? Because I know in the US, like, you can refill your prescription from so many different entities. So you could go to Walgreens and get their data, or CVS and get their data, or there's just a lot of, or even if you go to the, like, whether it was prescribed, it's through different insurance companies use different electronic medical records. And so in the US, it's really hard to do, but like in Canada, it's all in one system.
Yeah.
You can get it.
When we were looking at the data, it was from, we had a CDC collaborator, so they were able to
Okay,
get
they
that
were
data.
able to get all of that.
I'm happy to connect you with them. I mean, Rich, so. But I think that for this type of analysis, that'd be really interesting to see if there's an increased frequency of inhaler prescription fills or prescription requests.
And if that varies spatially as a function of kind of smoke plume.
Yeah, that would be interesting. I am doing work that's actually, I think, one step better than that, but we'll see if it comes out with anything that's on wildfire smoke in schools, and we can get so kids in elementary school have to show up at the nurse's office to use their inhaler, so we've got the data from the nurses at a bunch of schools that we're working at, and so we'll see. I'm still skeptical that we'll see a signal there, even with, and that'll just be PM 2.5, which we know is associated with asthma exacerbations, but we'll see. Yeah, I think it's cool. Yeah, see if we can get some data like that.
So there's a question online. Are these houses that are built today after a fire still contaminated with soil and air toxic exposure?
So the air toxics, the VOCs and the gases they sort of impregnated all the porous surfaces. And, when Joost was looking at his data, he said it's really high, but it's going down, right? You can see on his data that it did decline over time. And then interestingly, hold on, I'll go back to it. So you can see this decline in the VOCs in that one home over time, and this is days past the fire. But then, and the black line is the outside. But he found that, like in the places where he tested out using the carbon activated, Corsi Rosenthal box with carbon activated filters on it, it really decreased the VOCs quite a bit, but as soon as you turned it off, they went right back up, meaning that there was just a huge source of those VOCs there. So if you completely go down to the studs and remove everything and rebuild, then you wouldn't have those VOCs from the fire in the home for that. In terms of the soil, you'd have to remediate the soil outside. And there's definitely been work on that. But, and if you clean, I know that people, when they took down their drywall, they found ash between the 2x4s. So the ash was getting everywhere. And if you cleaned out everything, all the vents and got rid of all that, I would imagine that it wouldn't be from the fire, except for the soil outside, which you can then track back inside. But I think it wouldn't be a problem, and especially the completely rebuilt new homes, there could be these chemicals from the new materials, but not from the fire. It could be that individuals who clean their homes missed something, and therefore there's something still there.
What do you say to people when they ask you when it's safe to return? And what do you think we actually need to know to answer that question?
There's a lot of things I think we still need to know. I tell people I can't tell you when it's safe because I think that's a very individual level of feeling safe. I just say that, we saw that the VOC levels declined over, I think it was about 2 months afterwards, it seemed to get back down to the normal levels. I also always, like with the LA fires, like the smoke duration was a lot longer there. So it could be really different. And then one thing that I'm focused on is not only understanding these health impacts, and I want to find a way to follow up people longer to see something. We've quickly looked at another wave of the survey, which was done 2 years after the fire, and it was still at that same 33% responding any symptoms. There's a lot of caveats to all of it. I'd like to look at who continues to have the same symptoms or which ones go away, try to get at that. I think we need to know what's a normal level of VOCs inside homes, because when we're looking at this, yes, it's much higher than outside, for sure. But what are normal levels of these inside homes? And what's the variation and what causes that? And I think that's one of the things that happened with insurance was we don't have indoor air quality standards of any of these pollutants. And therefore, they were like, well, we don't know it's because of the fire. And so if we had something of I don't know, even if it's, I think it'd be easy to get at maybe what's normal at some point, if we sense in enough homes, a variety of homes, maybe we can get to that point, but then even saying like, is that associated with health impacts? Like, so one of our collaborators, their home was one of the homes that we sensed in, and they saw that theirs were a little bit higher than some of the others, and they wanted to know, and someone said, well, you are closer to 36 than any of the other homes. Oh, right. You know, it's just these things where there's a lot of factors at play, so. And then the other thing is that from a health perspective, and this I'd say even more, we don't really know the health impacts of these lower levels of VOC exposures. So the standards that are available for, say, occupational health are based on either animal models or really bad industrial accidents that were at really high concentrations, and we extrapolate down and create a standard. But generally, occupational standards are set higher than what we set for the general public in general. And then there are other standards for some VOCs, but they're based on endpoints like cancer. And there's other health endpoints that could be at different thresholds. And so, we don't really have a sense of what happens at, like are some of the health impacts that we experience on a regular basis due to our exposure to VOCs because we have so much combustion. You're right in the line, so I know Forrest,
Go
and
ahead.
then I know
So this probably won't be the last large exposure in an urban setting. I'm wondering if you've thought about your next experiment and ways to potentially more precisely document the exposure. I kind of asked you this at coffee earlier, but potentially with low-cost sensors that can be deployed into houses, or even I think there's like personal sensors that you can wear around for personal exposure too.
So I've been
Comparing that with surveys is really interesting.
Yeah, I've been talking with people about the possibility of doing that, say, right now with the LA fires. There's a lot of potential challenges with that right now, but so with the low-cost sensors, I've been really interested in this VOC question, and I don't think we have good low-cost VOC sensors. Like Purple Air will sell you one to put on your Purple Air sensor, but my understanding from talking to people who have tested them is that
You'll get some kind of signal.
you get a signal. What it is isn't really clear. And so, and then of course there's so many VOCs, right? Even if we had a good sensor for say benzene, is that the only one of concern? We know it's of concern for health, but like what about, all these other ones? And there's so many. But we could do that for PM 2.5, for NO2. We can measure it, we can get low cost sensors for some of these things and put them into homes, and there's definitely people from LA who are asking for that, and I'm talking to collaborators who have those things that we can send out and maybe partner it with surveys and also go longer term. That would require quite a lot of investment, and we know that's challenging right now. Sorry, I'm trying to get at all of these things that you're trying to say. I feel like I really want to study this. I think we could also look at, there's been enough of these now, these buoy fires, where maybe we could get people at different stages past it to try and capture these longer term impacts. Maybe we reach out to people who were affected by Santa Rosa or other things, but I feel like it'd be a long-term study, and getting a cohort study would require a large NIH grant, and
Just like one quick follow-up on not the funding, but are there concerns about from like the epidemiological side, or I don't know, from like putting sensors in people's houses of like, their mental health with seeing the signal, like understanding the signals, and not like misleading people, right?
And I think I'm hoping, so part of this research group wanted to come up with something to say that these VOC sensors from Purple Air really we're not sure what they're telling you. I think that would be important to give to people before they spend the money on it, or like tell them, or if we could figure out, is it pegged to one VOC and it's giving you a pretty good signal of that? But I think that's important to not mislead
I think that would be really interesting to see. I think for some people, knowledge alleviates the fear because you have some information about what's happening in your home. But I don't know. I'd have to look. I bet there's some papers that have looked at that in terms of like how that affects people. It could be that some people it raises concern. Oh, well, I know Shelley Miller has a study on this. So they have these personal sensors, the Atmo tubes, and they worked in North Denver. And I only know this because I was at her student's dissertation defense. And they found that actually, like, people were so concerned about all these exposures due to Highway 70 construction, but then when they wore them, they realized that they actually had much higher levels of PM 2.5, like inside their homes or in other places, and it wasn't actually the construction. Like the levels near there were actually much lower than other places, and so it was a learning experience in terms of that. And she found that the participants, they were really excited to get the personal sensors, and they were really excited to sort of figure out ways that they could change their behavior to reduce their exposure. I mean, I think some of them, might have been spending a lot of time with smokers, and of course that was going to be much higher and things like that. So, and then I am collaborating with some folks where we're working with some community organizations that are putting low-cost sensors in their communities, and so helping them understand that data so that it can inform what they do. And so I'm excited about that project which will go on this summer. But I think there's a lot of other people who've been doing this work. Shelley Miller is on the Boulder campus, has been doing a lot of that sort of very community science type things where people register smells or other things. And she could probably answer that. In terms of, I don't think she's connected it with mental health though. Looking at Bob Forrest because he's working with her.
I don't know if she has, but we have the project with Erica at DU that will probably do that with, because that's all Denver Public Schools. So we can use that same data set that is publicly available there for that work. And I think one thing to add on to Brett's as well, it would be really nice to get at least some level of biomarker collection for these cohorts as well. Again, where's the funding for that coming from? But I think that takes away some of that self-bias and self-reporting questions is if we have biomarker indicators of kind of physiological responses, that would answer some of the questions too.
Yeah, I know that, I feel like I was looking at something where people were gonna get, I know that there's a group that's starting work on the LA fires where they're gonna get medals.
Okay.
So it's more a marker of exposure than response. And I think that's okay. I think you also need to get measures of the stress response as well, but there's problems with that because there's so many things that affect that marker that are not just stress response. So there's just, I have to say I struggle with a lot of the biomarkers, but I think the metals one makes a lot of sense. But then of course, there's also like how long these things stay in the body, and could it be metals that they had before? How can you figure out that it's this? Because when one of these things happens, you don't have before data to compare to.
Yeah, that's true.
There are no other questions. Let's take Colleen again.
Cool. Yeah.